Today, I'm joined by Dr. Andrew Dowson, a GP and migraine specialist. He has been at the forefront of migraine and headaches for the past 30 years. Dr. Dowson, in his 30 years, has published over 120 clinical papers. And today, we're going to be discussing and putting migraines under the microscope, looking at causes, treatments, and his experience. Andy has had a very exciting career and we're very fortunate to have him on today. I've personally known Andy for over 8 years and he's changed, challenged and piqued my personal interest in migraines and headaches. And one of my favourite statements, and I paraphrase from Dr. Dowson, migraine is multifaceted and so is the treatment. Andy, I really appreciate you joining me here today, and I'm really looking forward to discussing migraine and your history and career in migraine. So thank you for joining us today.
That's no problem. It's a pleasure.
Andy, I think one of the main questions I need to ask you in the first one is where did it all start? You've had 30 years, well, maybe more years of experience in migraine. So where did it all begin for you?
Well, so I was a junior doctor. We weren't taught very much about migraines. So this is my first experiences were people coming into casualty with hemiplegic symptoms and hearing this term migraine, and really not knowing much about it. Then moved on to slightly kind of more into the career. I was doing SHO jobs, did casualty, and then I worked in Guildford and I did various jobs, including working with a chap called John Patton, who's quite a famous neurologist, and he was particularly interested in migraine. And then he became quite interested in the new crop of drugs that were coming along, which are called the triptans. Sumatriptan was the first one. So with him, I was involved with some of my first studies. Then went off and did some general practice. And then in general practice, realized that in the training section, there was hardly anything on headache. Headache was mentioned, but it was very jumbled and there wasn't a very good structure. So realized there was a bit of a hole there really in the training. Having finished doing the work up in general practice, I then decided that I would actually join forces back in Guildford with one of my old colleagues, and we set up a research unit and started doing some more work in headache again, and did a lot of clinical research. One of the reasons I did it was, though, because when I was in general practice for that short time, one of the partners' wives had really severe headaches. It wasn't straightforward migraine, but very difficult and very refractory. And so not only was there a training issue in primary care, but there was also one to do with lack of being able to manage some of the patients. So the whole interest kind of got fueled and one thing led to another, and I ended up doing migraine and being interested in that ever since.
Was it because when I was reading your bio, I've got to be honest, Andy, because I've known you for years now. I've probably known you for the best part of 7, maybe 8 years. And we probably had a conversation. We were doing the charity tours when we were talking to the migraine action. And that was incredible. But then it was this one fact, and we did start the introduction. There's over 120 research papers that you've published. Not 1 or 2, that's 120.
Yeah,
that's a lot of research papers that you've actually kind of published. Do you think the research attracted you, or was it just understanding migraine more that really got you into it?
So I was doing some general practice and helped to set up a research unit with a colleague, Michael Gross, and the research then led to papers and publications, and then not only just about the research, but other things as well. And then ultimately, some of those papers started to become the foundation for considering doing a PhD. So I did a PhD in measuring headache, and there was 10 or so papers that were the red line was measuring headaches, and that was my PhD. So there was pharmaceutical research and there was non-pharmaceutical research as well. There was, I think, things that were slightly more academic to do with the PhD.
So did you, when you set up the clinics, because I remember one of the biggest parts of your career was setting up the Surrey Headache Service, which you're still running to date right now, and it was interesting because you're seeing a lot only as it from a research perspective, but you're now treating patients as well with migraines and headaches. Can I use the word treat? Am I allowed to use the word treat nowadays?
Treat or manage.
Yeah, treat or manage. But the thing is now, I think when speaking to all the neurologists, even speaking to yourself, there isn't a treatment for migraines. There isn't. It's more about management, isn't it? And looking at the symptoms and supporting with that.
There's no cure, but there are ways to manage or to sort of help to manage individual attacks or to think about more long-term preventative strategies. But you got to remember, back in the early 1990s,
Yeah.
there were hardly any headache services. So I was there doing the research, and there were one or two. There was Queen Square, and there was the City of London Migraine Clinic and Princess Margaret Clinic.
Yeah.
But there weren't really an awful lot of other established headache services around. So I was then approached by King's in the mid 1990s. Would I go and help them to set up a headache service there at Denmark Hill, which is sort of kind of first stepping out of the research kind of arena into clinical practice. And I was there doing that at Denmark Hill for 20 years or something like that. It was a long time I was actually helping to drive that, but it became my opinion that it probably isn't the best. Hospitals are not necessarily the only place where you can deliver headache care. 97% of the population or something have a headache at some point in their life. So we can't deal with that in hospital buildings. We haven't got enough staff. We haven't got enough kind of physical kind of plan. No rooms to actually see people. So we really needed to kind of get the messages out into primary care as well, and to kind of try to look at what resources were available in a particular area and how we would best deliver care for the whole population. And to do that, we have to recruit and educate, all the types of people who might be seeing headache.
Yeah.
So that includes, the primary care sector, but also perhaps, if people go because they think they might think they've got headaches because they've got something wrong with their eyes. So they go to the optician, and the optician might say their eyes are normal, but perhaps they could then signpost them somewhere else that might actually be more likely to help. And so if they had bad posture or neck, perhaps they would send them to a physical therapist, or maybe the first headaches come to light during a pregnancy. So it's actually kind of that type of team that would be looking after the first kind of parts of the journey for the headache management. So you can imagine that the people with headache, if it's nearly everybody get a headache, those people are seeing all sorts of different people, from pharmacy to nurses to doctors to other kind of allied professionals, and there's always an opportunity for somebody with an interest to therefore identify somebody who isn't really quite doing what they should be doing for their attacks and are more disabled than they necessarily need to be, and start to create an intervention that would then turn that person's fortunes around.
So okay, that's really interesting, Andy. Like, looking at all the research that you've done, you've probably looked at like the causes and treatments and management, but can you explain a bit more about what the difference is between a headache and between a migraine? Because a lot of time people will say I've got a migraine when it could actually be a headache, and what's that big difference between the two?
So headache or head pain affects many people. There's lots of different causes. So you can imagine if somebody had a headache and they were trying to kind of work this out, they would need to have a way of working through what potential causes could be and what was the most appropriate for them. So from a medical sort of perspective, the first thing that we would want to exclude are people who might have something that was quite sinister or problematic. So, if somebody has an acute illness with a headache like meningitis or a burst blood vessel, they need to go off straight away to casualty to be assessed and sorted out. And then there are people who have serious and problematic things like, possibly it isn't the most common presentation for a brain tumor, but if they were to have a brain tumor, usually they'd be on what's called a 2-week wait. So rather than going to casualty, if there are some red flag symptoms, they would be directed to be investigated within a reasonably short space of time. Then there are other conditions, like if you have high blood pressure, if you have problems with your teeth or your ears or your sinuses, or there's lots of other things that are not really a primary headache condition, which are actually also something that we need to consider. But after you've thought about those things and you've come to the conclusion someone really has a benign primary headache condition, you then have to kind of work out what symptoms they're getting and what is their primary diagnosis. So it broadly falls into the people who are having headaches every now and again and the ones who are getting them a lot of the time. We have an arbitrary cutoff. If you're having headaches more days than not, it's called chronic headache, whereas you're having less than that, it's episodic headache. And then, so within the episodic headache, some people will have lots of other symptoms: nausea, light and sound sensitivity, one-sided throbbing, that's migraine. When they have less than those symptoms, they're just having a lower grade background featureless headache, that's mostly the tension type headache. A single question, the migraines tend to be more disabling than the tension type. That's to do with the episodic, every now and again headaches with normal in between. The chronic ones, there's a group of headaches where you get the headaches just for a few hours at a time. They're called the trigeminal autonomic cephalalgia. The most famous one's called cluster headache, and they have a whole load of other symptoms that go alongside having them with these shorter headaches, which can be daily for a long period or for a relatively few weeks. And then we have the headaches which are there pretty much all the time, and they're often complicated by people taking too many painkillers.
Oh, really?
So that's if you're using painkillers more than a couple of times a week, that leads you to have lowering thresholds and higher frequency. So and most of our patients in clinics will have chronic headache and will have an element of medication overuse, worsening of the symptoms.
Are you seeing that quite a bit now recently with like more people using painkillers?
It's always been the case all the way through. I think we didn't recognize this. So the first sort of period when in my career was with Migraine Action, drawing some charts that actually identified kind of what the visual representation might be of this, and then suddenly people started to twig that this might be a big problem. And in this country, a lot of the drugs involved are bought over the counter. In other countries like the United States, it was more the prescription sort of medications. So although any rescue drug given more than a couple of times a week can lead to more headaches, the drugs with codeine and caffeine tend to be the ones which are most likely to give the most problems for the patient in trying to address it. Because if those are in the drugs that you're using and you stop using them, it might take months before their effects really go away. So you're then left with no real painkillers, but lots of headache days and a lot of disability. But the big thing with regular headaches is prevention, whereas the thing for the rest, kind of for the every now and again headaches, is mostly rescue. Although rescue is also used in chronic headache, it's a mindset of what's the most important element of the treatment.
Wow, that's because like you're talking about that, it just blew my mind a little bit. I knew there was a big problem with pain medication being overused, but I never realized it was so prevalent in the migraine communities.
Yeah, well, when we first started talking about this is probably 25, 30 years ago now. There were various clinicians from other parts of the world who were talking about it, particularly in the US. So a chap called Nina Matthew and Silverstein and Lipton were probably the ones most associated with the kind of the beginnings of the understanding. In the States, there's a bit more of a culture for taking a lot more medications than there would be here. And I think that, probably that's why they were right in the vanguard of it. But they basically laid out some ideas that not only was this happening in migraine, but also in lower grade tension type headaches. And there were also some sort of slightly more unusual types of headache that it could also complicate as well. They did some research identifying that for rescue drugs, if you were using ones with codeine and caffeine to treat your every now and again migraine, you are 3 times more likely to develop daily headache. So we found, so most of that is in prescription drugs in the States, but in the UK we had the same issues, but often with over-the-counter drugs, because we were allowed codeine and caffeine in our over-the-counter drugs, whereas they just used to have the caffeine, not so much the codeine or opiates. So, but it's not just, all analgesic, all rescue drugs, if given more than a couple of times a week, tend to maybe help at the moment that you're taking it, but lower your threshold for you to have the next headache. So you get into a vicious cycle with the headaches.
Andy, I always thought I thought caffeine played a major role in one of the causes of like headaches, or am I wrong here?
Yeah, so caffeine is put into analgesics to allow the drugs to be absorbed more rapidly and get into the brain more rapidly. And so they actually can be helpful. So some people will find if they have migraine once a month, if they have a strong coffee, it sometimes actually helps with the headache.
Yeah,
it's when you start to get kind of it ramping up and you're using a lot. So basically the odd, as in many things, kind of things in moderation are usually okay. But if you start to kind of use more and more and more, it can lead to problems. And And although we were talking about this in headache, the analgesics potentially leading to more pain, in fact, it's now identified that in quite a lot of other pain conditions, the same thing may also be true. Generally across medicine now, we're a lot more wary about putting people onto regular analgesics and often trying to use strategies to sort of rationalize what they're doing and trying to kind of reverse any of the negatives.
I mean, because we were talking earlier about like triptans before, like, before we started the whole conversation, we talked about how like triptans were used, and you said one of the biggest, because I asked you, said, what's the biggest change you've seen in migraines? And you mentioned how triptans have changed and they've changed the game a little bit. But like with triptans kind of coming onto the market and you've seen the benefit that they've had with migraine sufferers and patients, what's your like outcome? How do you think, right, this person needs this triptan, or this person needs this, or this person needs that? What kind of brings you to that headspace? What makes you make that choice?
Well, the triptans have been around a long time now, so we're talking, more than 30 years ago. It doesn't seem possible, does it? But it's about 30 years ago. And before that, we had analgesics and we had some old-fashioned drugs. The old-fashioned drugs actually were part of the kind of foundations for the thinking that ended up with the triptans. So ergotamines were used and found to be helpful. It had been found by chance that there was a fungal sort of contamination of certain grains in countries, and it was from there that we had the development of the ergotamines. And then it was found that they just help people with headaches. But when the science was worked out, they work on a number of different receptors or buttons, and some of those could give unwanted effects. So the people who did the research for the triptans tried to identify which were the important buttons for migraine and develop something that didn't work on the unwanted buttons and get rid of the side effects. And that's where it all came from, Sir Pat Humphrey. And, obviously they were very successful. So suddenly from having, maybe half the population not having something that would actually work for their headache, we had things that potentially could work in a whole group of people who previously were not well served with what was available. And sumatriptan was the first drug that came along, and then it was joined by 6 more. The 6 others didn't have so much of something called 5-HT1A activity. So although sumatriptan for some people make them feel a bit more nauseous to begin with, and then when the headache starts to clear, the nausea starts to get better. The ones that came subsequently tended to have less nausea. So you needed to have, that was one of the things we learned to begin with, that basically there might have been a particular reason for using one of these other drugs rather than the original drug. And then there became some that were delivered that were dissolved in the mouth, for instance. So people who struggles to swallow tablets, would have something that would be in solution in their mouth, and then it could just be swilled down into the stomach. We had nasal sprays. Not all of the nasal sprays are equal, but basically, if you can have a nasal spray that you kind of find will have about a third absorption of the active compound from your nose. That means then if you tend to be feeling quite sick or vomiting, with a tablet that would be a struggle to get any absorption, but the part of it that was absorbed from the nose would then have enough chance of having an effect and be more rapidly effective. So for the early vomiters and the people who needed speed, because the headache becomes more difficult to treat the further into the headache in time or severity. So if you needed something to be quickly effective or the vomiting, they became useful. And the big daddy of the triptans was the injectable version of the sumatriptan, which tends to have, so as you go for more power and more speed, you'd get more side effects as well as more efficacy. And then of course the flip side is that they worked for them, but they felt terrible on them. So you wanted some more gentle ones, and so there's a sort of hierarchy of power as well. So there are a number of considerations when you're trying to work out, the right drug for the patient. But I think most doctors would probably start with the middle strength sumatriptan, 50 milligrams, and then if works with side effects. You can step it down to something gentler. If you need more power, you can step it up.
Yeah.
And there are things you can take with the triptans to make them work better.
Yeah.
So something to overcome that gastric stasis, or take a non-steroidal anti-inflammatory with the triptan, it makes it work better. And you can come to the best solution for that individual. But what is the right solution for mum might not be the right solution for daughter.
Yeah.
So basically, it does need to be bespoke.
Oh, actually, that's interesting. Though. You kind of said like the right for. Have you seen migraine be like through the family, through her, like hereditary? Really? So you've seen like parents who've had, or grandparents, parents have got it, then the child's got it.
Yeah. So the person normally who comes in, part of the history taking is there anybody else in the family with migraine, and nearly all of them will have one of their parents or a grandparent or an uncle, and you sort of say, well, you can blame your genes on that side of the your heritage, and obviously if they have both sides, they were probably almost doomed to get migraine.
Oh, wow. So are you saying it's genetics could play a major role in it?
Yeah, there's a lot of genes being identified as being related to migraine. The problem is it isn't just one gene, so it's difficult to kind of be able to. It's a complicated study.
Yeah.
And it might be that it's a number of these together that are important, and so there may be thresholds or combinations of the genes which are important to get you to be an actual sufferer. So 20% of women have migraine, but if you have a parent with migraine, it probably doubles the number.
Oh, wow,
if you have two parents, it might double again. If they've had it from being young and severely, it's even higher chances. So there's a definite link.
That's I did not know that. That's actually blew my mind a little bit, because like you hear about it, but now knowing that genetics play a role, do you think that could be like a potential future treatment for that? They look at genetics and see what gene it could be that's doing it, because I know people are focusing a lot more now on DNA and genetics and looking at genetic codes and everything. I know we've got the CRISPR, like that technology is coming out quite rapidly now around. I know it's designer babies, but do you think there could be a potential where we could identify the genes for it?
Well, as I say, it isn't. There has been an effort to try to find the genes, but the numbers of genes have kind of been rising, and it's between 5 and 10 genes, I think, at the moment that is actually kind of the most sort of identified as being potentially related. So it isn't one gene. If it was one gene and you could work out what that one gene did, maybe then you could target what it does to be able to actually be a solution, either prevention or rescue. The problem when it's multiple genes is it's, you might know how each of all the genes are, but then you've got to work out how those things are interacting. So it becomes quite a complicated thing.
Yeah.
So if it was one gene and one button that was, that gene was responsible for it, it would be quite easy, but it isn't as easy as that. So that, so the triptans, which we talked about, they work on something called 5-HTP, 5-HT serotonin, whereas the next stage along, and what has become in the last 2 or 3 years, we've had CGRP, a different protein.
Yeah.
And so, there are different targets that are identified, and some may come out of the gene research, absolutely, but at the moment it's sort of more that we've identified proteins, and they're being chased down to see which ones of those are going to be relevant in the migraine.
So like, now, saying what you just said and looking at the idea of genes, I mean, in your experience, like in your literal 30 years of experience, have you found a common cause of headaches or migraines?
Well, I think there's,
it's a big question, Andy.
it is a big question, but I think that, so migraine affects 20% of women, 10% of men. So although there's a genetic link, there are plenty of people who can't identify people because there are sporadic cases as well.
Yeah.
So probably the most important thing is your heritage. So
really?
You will find other people in your family, but at the same point there will then be these other cases, and then there are the things that happen to you along your life's journey that actually, so you have a car crash and a head injury and you have more headaches, you're more susceptible afterwards. So for women, there can be the time of their periods, the kind of the time of the month is,
Yeah.
so there can be other things influencing them. And, I guess that, one way to think about this is that a migraine has a sort of threshold theory that, you start off and maybe you have a period of time where you might only have very occasional migraines because your threshold's quite high, and lots of things have to happen, missing a meal and a stressful event, and eventually you get to the threshold where you could trigger off an attack. But the question is, why does that go down on occasions? And, so with the medication overuse, regular painkillers, even if the painkillers are given for something else, painful hip or knee, that may lower your threshold. The uncontrolled migraines probably lower the threshold. So once you get to a certain number of migraines per month or per week, it becomes a self-fulfilling vicious cycle to actually kind of have more attacks. So that's one of the sort of things that might do it. But then, not sleeping or being stressed or having a whiplash injury and a sore neck, lots of other things can play on that threshold. When you have the individual attack, the plan is to try to nip them in the bud so that you get rid of them before they became sort of longer term, which would then make it more likely to have the next attack. And when you are having a lot of attacks, so more than about 1 a week or 2 days a week affected, you need something to push up the threshold. So the idea of the preventatives is to actually and the threat and the kind of preventative strategies. I mean, people immediately think about the tablets, the old ones like Pizodofen and Propranolol, the beta blocker. There are newer ones, but there's all sorts of non-drug approaches. There's the supplements, there's Migrolens glasses. Trying to people who have sensitivity to light, they might try to filter out the light that it kind of light wavelengths that they find problematic. Tend to be the two ends of the spectrum, red and blue. Some people look at foodstuffs, IgG hypersensitivity. Other people, there's a Kefali device. Some people like. So there's a whole, and there are things coming in and out of popularity all the time. So there were other supplements and other herbal treatments like feverfew, which perhaps is less commonly suggested these days because it has side effects and doesn't work in that many people, not as many as some of the other supplements. So there's, there was, in one of our other headache conditions, there was a sort of grassy herbal treatment called Kudzu that was helpful. That was in cluster headache. So people have talked about mushrooms, haven't they, recently in cluster headache? So
You're joking, mushrooms?
Certain sites of mushrooms.
Oh wow!
So there's always things which are coming in and out of favour. I think that somebody kind of gets behind one of these interventions often, and it has a popularity, and then it's whether is there enough evidence to support its use, and whether or not if it isn't really working, people work that out and it becomes less popular. But we try to base what we do in the medical world around evidence, which is, again, you come back to the studies. So where possible, we always try to be evidence-based.
I mean, I think that's like one of the biggest, but the evidence basis is needed for, especially not just in migraine and headaches, in other conditions as well. And you brought a good topic there where we moved away from triptans towards like supplements, and like obviously we've got Dolovin, so we've done our 130 patient clinical trial for migraine patients, which has been good. And I think that was actually how we got introduced, was when we introduced Dolovin to you. And you've used it in clinic, and I know you've used things like the Kefali device, and I know you've looked at using it with triptans as well. And that's one of the things that I quite liked about your approach, was the fact that it was multifaceted. The fact that when you were looking at the treatment or management of migraine, you weren't just kind of going, right, you've got to take this medication or you've got to do this. You were assessing it and saying, right, we're going to try this with you and do this with you, but we're going to add this. Am I right? Because that's what you normally do, right?
Yeah, I mean, so it depends. So the first thing is to get the diagnosis. And so, we ran through a kind of sort of mind kind of map of how you might get people into broadly the right groups. And in migraine, if we just took the migraine groups, if you had once a month migraine, the biggest need would be a rescue medication. So I would have a sort of discussion with the patient about, what they're already using or what they've used, how frequently does it work, over what time period. So, what we're looking for is a consistent treatment that would get people back to their normal activities within a couple of hours. If they're not achieving that, they should probably be thinking about how to modify what they're doing. Could it be a bigger dose of the same thing, or introduction of more than one thing at the same time, or do they need a more prescription-based approach? So the triptans or whatever, there will be other rescue medications that become available. So basically that's the first thing. When you do the frequent patients, the ones who are having headaches, kind of more days than not, although all of the rescue is still relevant, the mainstay there is to have a slightly different approach, which is around how many days are you getting your headaches? How long do they last? If we were to introduce something, could we demonstrate a reduction of your disability? So that could be a reduction of the days or the hours within a day, or the intensity within that day, or the need for rescue drugs on the day. So there's a number of different things you could try to use to monitor how you're doing with a preventative, whether it's a prescription or non-prescription approach. And basically, if the patient, so rule of thumb is if you're having an attack once a week or more than 2 days a week, you probably need to be on a preventative. If you're on one, you possibly need a higher dose of it, or a different one, or a combination of approaches. And the aim is to start to see the numbers reduce. And when something does well, it generally will reduce the rate by about 50% or more. Oh, wow. So that's a general rule of thumb. But it's not hard and fast, because as well as having that kind of in your mind, you have to have a discussion with the patient about what's their preference, what's their mindset. You might have somebody who doesn't want to use the non-prescription things, or somebody who doesn't want to use the prescription things. There is a second tier, of treatment in people who try a lot of different preventers without a great deal of success. And we have now this group called the high-cost drugs, with Botox and monoclonal antibodies for CGRP. There will be CGRP antagonists, and they are higher cost to the NHS. So NICE have laid down rules for their use, and they may come into play, but to get to them, you've got to have failed 3 preventative drugs. Wow. So basically you have to go through a process to get to there. So all of these things are together how you actually come up with a plan that you can agree with the patient.
Wow, because I know you recommend Donovan to patients when you're trying it out. And to be honest with you, Andy, you've done a massive amount for us, because you've been such an advocate for it. And we've seen a lot of other neurologists now use it, and we get a lot of positive patient feedback where they're seeing success. And I think one of the things I remember you said to me was you said, Dilly, it's not about completely eradicating it. It's having those crystal clear days where you have those days where you're thinking straight and you've got your life back, because that's the biggest debilitating, because no matter what we say, migraine is a debilitating disease, and when it's harsh on families.
So I think there's lots of other clinicians will tell you they have slightly different ways of looking at things, but I think broadly, if you look at disability, it's related to the amount of migraine usually that the patient's getting. Most of it is related. So if you had, one migraine day, you'd have certain amount of disability on average. But if you have 2 or 3 or 4, the more you have, the worse it gets. And the lower level background chronic tension type symptoms tend to be much less disabling. So if we're going to measure one thing, I tend to say, ask the patients how many crystal clear days, how many background days, how many migraine days. And I'm trying to kind of move them from having the disabling migraine days, through to, I'm feeling a lot happier for the patient if they're getting, background headache days rather than migraine, and even happier if they get to crystal clear. But the bottom line for the patient is often not necessarily headache free, but it's, disability free. So what they want is to be able to know that they're not going to be disabled, so they can pick up the child at 4 o'clock, even if they start off that day with a migraine. That they would be able to plan to go to a wedding in 2 weeks' time, and because they've got an antidote to that situation. So they want to do that, but they also want to have less threats. They want to have less sort of near misses as well, or treated episodes. So within the broad brush that you want to be back to normal within a couple of hours of the rescue, you want to sort of be reducing the number of days. we want to be sort of deploying all of our various options in order to do the best for the patient.
Yeah, but I'm gonna go take a step back now, Andy, and you're gonna have to correct me on this, right? So, because I remember when we first came down to the clinic in Guildford, and I remember you showing us the bottles of botulinum toxin, and because a lot of people, obviously people know what Botox is, and everyone just thinks it's for making yourself look pretty, and I remember you talking about like injecting Botox, but I think. And I hope you don't mind me saying this. I remember you said that at one point the NHS were not funding it because the minute you got under a certain threshold, like 15 days or 14 days, they wouldn't pay for it. And a lot of people, they were like, I'm 15 or 16. They were still getting to 14, and it's just like, no, we're not paying for it anymore.
Yeah.
And has that like hindered your treatment with migraines, or how have you found that?
Yeah. So
I don't know I'm asking this. I don't know.
No. It's a fair question, and within the NHS, obviously, the cost of everything is actually quite important. Although the biggest cost to the NHS is the people who are working it and the buildings, and relatively the cost of the drugs is relatively small compared to all of the rest of it. We still try to kind of, we're custodians of a budget. And so when things are, particularly when things are more expensive, there is a tendency for the National Institute for Clinical Excellence to have committees, and they will try to have experts and patients and then people from other areas as well who can kind of cast their eye over the actual kind of area and decide how best, what rules can we put in place to get the most value for money out of the various treatments. So with Botox, for instance, the NICE guidance, which came probably 15 or 20 years after it started using the drug privately, but basically the basic rule was that you needed to have got chronic migraine, so headache more days than not, of which 8 days would have migraine features, at least 8 days migraine features, and fail 3 preventative drugs, and understand about medication overuse in order to be considered for it in the NHS. So you had to have a sort of criteria to actually, and then having got to that criteria and being decided that you're going to do it, these are the NICE guidance, you then, after 2 applications, had to have changed the amount of headache. So you'd have to go down in your headaches by 1/3 in order to continue using it. Certainly to begin with, you still had to have chronic headache in order to continue using it as well. So we had to reduce. So if you started off with 30 out of 30 days, you had to go to 20 days, but you still needed to have 15 days. So you have to be in a little kind of window in order to carry on with the Botox in the NHS.
Oh, that's so tough.
So it was a tough guideline.
Yeah.
And then, the next things, the CGRP monoclonal antibodies, rather than it being headache days, it's migraine days.
Right. Okay.
So you had to have chronic migraine to begin with. We now can use it in high frequency episodic migraine. So you needed to meet the criteria on diagnosis, but the days that were relevant were the migraine days. So you had to reduce your migraine days by 1/3, by more than 1/3. And in fact, if you have less than chronic migraine, you have to reduce them by more than 1/2. So there's all sorts of complexity which sometimes gets in the way, and then some of those rules can change over time. So some of those things get in the way sometimes for the patient, and they don't necessarily reflect what the patient wants. So you might have a patient who hasn't had enough of a response for the NICE guidance, and they tell you their lives have been transformed and they want to carry on. And you might have people who meet the criteria that NICE have laid down, but don't think it's enough for them to justify carrying on as well, even if it's an NHS thing. Although in the NHS, people are more likely to stay on because it's an NHS thing. If you're paying for it privately, probably you'd have if you don't feel it's enough for you, you're definitely not going to carry on because you're going to be paying for it. So there's slightly different. The different sectors have different sort of uptake and how you continue with the medications.
But I think that with migraine being so debilitating, having to go private, and I do really feel for some of those migraine patients because being a disability, they do have to consider going private. And I remember when we talked about Botox quite a bit, you were talking about how it can be, having to go private was the only next option for them, because they were finding such a benefit of it and they couldn't get it on the NHS because they'd missed that threshold.
Well, they may not meet the criteria, but then there could be other barriers, which is about availability of a clinic to give it. And
Okay.
And so there's all sorts of other things that come to play. And so the NICE is one hurdle, but there are other hurdles that can also be in place. So there may be nobody in your area that will actually be prepared to give it to you at all. That was certainly the case at the beginning. It's less so now, but it still can be that there are certain areas that the local health authorities are not keen to be engaged in certain treatments. So it can be made even more difficult. So if there's no availability to see anybody, how are you going to get it? That sort of thing. So it is difficult for patients, and it's complicated. But I think you just have to try to kind of understand what all of your options are, and then try and play your cards as well as you can to get to the outcomes that you're looking for.
I think it's the options that are available. I think now, the figures that I remember from, Migraine Action and Migraine Trust was talking about, there's about 10 million people in the UK who have a headache or migraine of some sorts. And 10 million people's a lot. It's 1/6 of the population. And so it's not a small thing, and their options are quite a lot. And even with the triptans, I think, because I think we spoke about this once before, where like people will start the triptans, but because it takes time for the body to build up, they get a little bit scared of them, or like they get side effects, or
they might worry about that. But the triptans generally have got very short half-lives and are rescue drugs, so there's very little build up over time, and they are safe drugs, and to the point where sumatriptan is now available, without a prescription. If you fill in there's a questionnaire you do with the pharmacist, and
brilliant,
this sort of thing. So there is, I think the scary worry about the triptans 30 odd years ago didn't materialize. We didn't have avalanches of people having problems with the drugs, and they became more accepted and so forth over time. They were expensive to begin with, and of course when they became generic, they became a lot more cost effective for the NHS. So there's all sorts of little considerations about how things get to be used as well. So the answer for the triptans are that they don't really build up in the body because they're rescue drugs, but it's not the same for the preventative drugs. So a drug like amitriptyline, for instance, which is an old-fashioned drug, you start at 10 milligrams, and then there's a sort of escalation of the dose, as most people need 30 to 80 milligrams. And there's a compromise between how quickly do you go with the escalation, because the quicker you go, the bigger the chance of a side effect. But obviously, the longer it takes to get to the potential benefits of the drug as well. So I think the issue that you're talking about the patient being worried about how long it's going to take and whether they're going to have side effects, is much more related to the preventatives. So whereas the rescue drugs, if you had 3 doses of a triptan drug, for instance, we did this with sumatriptan in the early days. We started off with 50 milligrams. We said they had to treat 3 attacks, and then we said to them, you could go down to 25 or stay at 50 or go up to 100. And we found that nearly everybody wanted to get something more powerful.
Oh, really?
So there was very small numbers that would. So they would. Even if they had a side effect, they would actually put up with the side effects, which was short lasting, in order to get better efficacy. On the other hand, if you look at the same sort of issues with prevention, if you get side effects before you're seeing any benefit with a preventative, often the patient will give up with the preventative before they even get to the kind of treatment zone of the drugs. So the decision making is much more about efficacy for rescue and about prevention. It's more about side effects.
See, because I think when we were talking earlier, you mentioned about IgE and histamine and the role that it plays in migraine. And one of the facts actually you told me very early on was, Dilly, about 5%, I think it's 5% of people have migraine related to food allergies or intolerances. And so
it's difficult for us to know. I don't know any of the absolute figures for it, but
but this is years ago now I'm talking about.
But the IG, the traditional sort of anaphylaxis, angioneurotic edema type of reactions, they're one thing, But it may be that it's more to do with the slower IgG responses that is to do with foodstuffs. So there is a sort of pseudoscience, and people will do a blood test and look at the various IgG antibodies to see if there's a positive. If it's positive, if it's negative, it's safe. If it's positive, it might, of course, having no reaction on you at all, or it might be actually causing something different, like bloating or something. Because they've been implicated in other things like IBS and so on. It gives you a more firm basis to start thinking about an exclusion diet. So some people do that. There isn't a hard science that supports its use. It's not going to do you any harm to do that. The biggest harm comes when people, say, right, I'm going to do an exclusion diet, and they end up taking, chicken breast and cabbage for 2 meals every day forever. And then they start to get kind of dietary issues and side effects from having a poor diet. So in a way, I think if people are going to do this and they're struggling, they might actually think about doing something like an IgG just to give them an idea of where to start.
That's really interesting. That is, I've never really thought of it that way, because it's kind of a bit of a difference, because people talk about the role of like histamine and how it could be, and it's funny, like, so I remember I used to refer to what I now know are headaches as migraines, because I said to you before about what's the difference between headaches and migraines, and what I found really funny was I always know when I'm going to get a headache, and my telltale sign of getting a headache is chocolate. If I'm craving chocolate, I'm going to get a headache, and then I get a headache, and when I'm craving chocolate again when I'm getting a headache, it means my headache's going to disappear. And I think you said to me, you were like, because people used to say chocolate is a cause of migraines and headaches, but you said to me, Dilly, it's not. It might not be the cause. It could be that it's hitting a sensor in your brain which makes you crave sugar or chocolate, and that is just a start. If I remember,
sort of. So. Studies were done a long time ago in children, and they were given normal chocolate, and they were given things that looked and felt like chocolate but didn't have the same ingredients, and it was hard to prove that the chocolate, the normal chocolate, was actually the trigger for the attacks. So I think it was called Suttle. It was at Great Ormond Street. So there were some studies that brought into question whether it really was the chocolate that was the cause. And with migraine, there is a sort of phasic condition. So some people actually feel kind of tired or have thirst or hunger, and that can go on sometimes for days, generally for hours. Then some people have these things called auras, where they get flashy lights or zigzag lines or numbness down a side or the words mix, which generally goes on for an hour, though can be elongated as well, and even chronic. So we have some people with chronic auras. And then most people, the main part is the headache and the nausea, light and sound sensitivity, which is usually from a few hours to several days. And then once that's beginning to get over, vomiting can be part of that, then you're left with a sort of hangover afterwards. So this is called a prodrome, an aura, headache and postdrome. And part of the prodrome, so the attack is already on the way, can be cravings. And the things people generally crave for are the convenience foods. So it's chocolate, cheese, citrus fruits, the things that are in the fridge that you can just readily get hold of. And it may be part of the migraine to be craving it rather than the cause of the migraine. So that's just the way of it. So I think a lot of people, it's difficult for a doctor who's in a headache clinic to give you a definitive view, because if cheese, chocolate and citrus fruits are a trigger for you and you've thought about it and stopped them, you won't need to come to see me.
That's very true.
And just like if the same thing with a physical therapist with potential cervicogenic triggering. So most of those, many patients who've had a success may not need to come and see me in my clinic because they're already better. So the people I see who've tried that are the ones that have often failed it. So I might get a kind of unbalanced view that all the people, nobody responds to dietary manipulation or chiropractic, because basically, the people I see in my everyday practice report back to me that that's been a treatment failure for them. But in headache, there's lots of treatment failures. and there's probably a need to have a bespoke view of that. We have the universe of treatments and which are the best ones for a patient, and often people will take several tries to get to the best for them or the best combination for them. So in many ways, the things that don't cause any harm are reasonable things to try, but don't keep on trying something that is actually failing you. Kind of move on to the next thing. Kind of if you've given it a real trial. What you don't want at the end of each of your little experiments is a question mark. You want a tick or a cross. Does it help or not? And I think you mentioned earlier, it might be that you did one thing that helps to a certain extent, and it isn't causing you side effects. You want to keep that, but it isn't enough to get you where you need to be. So you need to add something else to it. So you keep that steady and add something else in, or a series of things, to see if you can find a way to get to where you need to be ultimately. And it might be that it's multiple things that are required.
I think you've touched on so many topics today. That's just been incredible. But looking at the diet, looking at eliminations, looking at the triptans, looking at all the different things that are going on. And then one thing you touched on was the genetics of migraine, and maybe the fact that genes played a role. So my question to you is, what in your experience do you think is the future for migraines? Do you have an opinion on this?
Well, yeah, we'll have opinions on almost everything in headache. We hoped maybe 3 or 4 years ago that there would be a complete transformation because the protein CGRP was going to be a pivotal protein for the majority of patients. Of course, the problem then comes is that the pharmacological solutions are actually really expensive, so they can't be given to the whole population, otherwise it would bankrupt the NHS. But we haven't found that they have actually worked in every patient either. So they do work incredibly well for a minority of our patients, but they haven't really completely transformed my practice. They're another thing I've got in my clinic, which in my toolkit, which I can actually deploy. But we're definitely going to need other things, because we're not close to having something that is a sort of a global treatment for all the patients. So what we probably need to do, if in simple terms, if we have a cascade of things that happen in a migraine, the CGRP isn't right at the top of this thing, and approaching it is the cascades would kind of mix up with other cascades. It's not something that's probably likely to be pivotal. We need something that is near the triggers, that will therefore kind of stop the whole process for everybody. Now, whether that will ever happen, I don't know, but people will be searching for it.
I think it's
so we will be searching for something that is going to be more likely to work for a bigger number of people earlier in the attacks, both for rescue and also perhaps for prevention as well. And we're not at that point yet. And I'm sure that whichever area of medicine that you're involved in, whether it's a pharmaceutical company or a allied professional, musculoskeletal therapist, or whether it's a doctor, we all have patients who report back to us that they've tried. They often say everything, but they often haven't. They've tried a number of things, and sometimes at the wrong dose, but they think they've tried a lot of different things, but nothing's really worked for them. And wherever you work, there are those kind of patients. So we will need to continue to search for other alternatives to help the people who are not getting a perfect solution at the moment.
So you think the future is basically more research? Essentially, it's more research, looking at more potential drugs and looking at potentially more different treatments, and not just for the cause, but the rescue side of it.
Yeah, I think research will always have to validate ideas.
Yes.
But ideas can come from a number of places. These days, it's less likely for people to make an observation. So if you go back far enough in science, it was identified, how they found, cowpox, the treatments for smallpox, kind of the an observation that the girls doing the milking didn't developed the smallpox, kind of basically kind of led to a way to control smallpox. So it's not as likely that we're going to have those sort of easy observational wins now, because the world has moved on and everything's much more complicated. But there's still a place for clinical observation. And ideas may come out of that and may come from completely unexpected areas. So it may not be a headache doctor that identifies the next option. It could be somebody who's to do with treatment of blood pressure or ENT or dentistry. Somebody else could come up with an idea that turns out to be revolutionary. Who knows? But I think that so there's observation, then there's academia kind of coming up with ideas and ideas of how things are working in the body, which will then identify other targets. And then then there's the chemistry people who then trying to kind of find how to kind of act on the target that is actually identified. So there's a whole number of people involved, but I think there's observation, academia, and then research has to underpin the assessment to make sure that we're onto something that is actually not a bogus treatment. And I think that's the way we will gradually move forward in this.
100%. I do agree with that. All right, I've got my one last question for you, Andy. I've got to ask, if there is like one thing that you would tell a migraine patient to do, someone who's got migraines, what is like your top tip that you would say this is like where you need to start before you do anything?
It's a very difficult question.
Is it multifaceted?
Because I think different patients have different ideas and different preferences, and nobody comes with a clean canvas. Everybody's already got some things they've tried, and so you have to kind of tailor what you're doing according to the patient's beliefs and expectations and concerns. You need to actually kind of try to kind of think of them as a whole, and quite often that maybe migraine isn't the only thing that's important to them, so you have to take that into account. Having said that, I think that the most important thing for patients is to be more organized about the way they think about their health. It isn't just true for headache, it's true for a lot of things. When we're well, we tend to just kind of not even think about health, and then when things go wrong, we then are often not in a position to try to kind of introduce some of the simple things that might have actually been helpful for us. So when I was a boy, there was a lot of smoking, and then there was big campaigns about smoking, and the numbers dropped. The numbers are going back up again now, worryingly. But there was a whole process of the population changing about the way they thought about smoking, and there'll be other, asbestos in building, was another example that it was identified eventually that was a dangerous thing. So kind of there's a sort of collective thing as well that goes on in decision making. But I think we need to be more organized. So basically, if you have migraine, what's your lifestyle like? Do you have a regular routine? Non-regular routines tend to irritate headache. Have some basic kind of rules that you're trying to work to that would assess whether what you're doing is appropriate or not. So are you back to normal rapidly and consistently with a rescue? If you're having a lot, can you reduce the numbers? So it means keeping some sort of records often, at least when you're changing your approach, so that you can make sure that it actually does what you're actually wanting it to do. And part of, I know that you're interested in the supplements, and part of the whole mix is, what are the things that you can do which are easy wins, which are really not involving using medicines really that would have side effects and so on. And there's a huge proportion of people who are very interested in things like the supplements and lifestyle and so forth. And we have got evidence individually for the B2 magnesium and CoQ10. The advantage of something like Dolovent, of course, is that often it isn't just those individual items you need. You're not supposed to have a bee on its own, are you? So something like a Dolovent is like the cake with all of the key ingredients in it
blend,
and everything,
yeah.
and that actually makes it easier for patients. So obviously there's a whole number of things. So it isn't easy to answer your question.
No, I know, yeah.
I would. The question you asked me earlier was what was the first key step forward, and I think in my early years involved in headache, it was in the pre-triptan era, but as triptans were coming, and that's changed the way we think about it. A lot more scientific now, a lot more enthusiasm. There were no headache clinics before, or there's very few headache clinics before that. Where are we going in the future? Very difficult to know. I hope that we don't get that the ground that's been made in headache, legitimizing clinics and all the rest of it, as pressure comes on the NHS, we don't see the enthusiasm being squashed. What I'd like to see is, this is something that makes a big difference to people's lives, and we shouldn't be kind of just judging whether something's serious based upon whether it kills you today or, I think things that kill your quality of life have their own importance, and I think that we need to kind of make sure that we don't let that kind of out of focus for the NHS.
Yeah, I think one of the key takeaways I've got from what you just said was like it's a case of for a migraine sufferer or a headache, someone who's got chronic headaches, is to basically do a bit of their own research, and there's so much research. Like the Migraine Trust have some good stuff, and if you're a big social media person, there's people like Amy Mowbray from the Migraine Life, and there's the Chronic Migraineur and the Traveling Migraineur. They've got some really good content that they put out on migraine. And I think if you have like a headache or have a migraine, that community is such a powerful tool, and being able to talk to people who are in the similar boat as you, and they are a lot of people in the boat. I think my takeaway from you is that you should be able to spend that time with those people and talk to other people and do your own research. So when you do come to your clinician and you're speaking to them, you have a much better understanding of what your steps are, what the next steps are going to be. Would you agree with that?
Yeah, I think you actually covered quite a lot of ground in that, but I think you're right. I think that unless you're willing to engage, your chances of success are going to be much reduced. I mean, there isn't a magic bullet.
Of course,
it's hard work to actually kind of get to what you want to get. But I think that if you're prepared to engage, keep records, kind of try to get information. Obviously, there's a lot of information out there, and not all of it is really kite marked. To try and get some kite marked information if you can, so that you've got credible ideas, because there's all sorts of stuff that might be out there that would be slightly more questionable as well. So sources like the Migraine Trust, for instance, would be excellent.
They have a migraine diary, if I'm correct, as well. They have a diary that you can use to track your migraine, which is really a good tool to give to your clinician. Say, absolutely, this is my migraine diary.
So all of that, I think, is spot on, and supporting each other through groups, whether they are sort of local groups and you're having coffee mornings, or whether it's kind of a trusted group that you become part of, and you get an idea, a feel for what's happening with the new things, what's being researched. I think is there, I'm not doing well at the moment, but is there anything in the pipeline that the collective have actually come across that might be of interest? All of that sort of thing can only be a good thing for the headache patient.
Yeah, 100%. Andy, I can't thank you enough for this. This has been an absolute pleasure having you on today. And I think you really covered a lot of topics, but I think a lot of people are going to have a lot of questions. And are we okay to mention that you run the Surrey Headache Service? And if people do want to reach out, they can contact you and kind of like ask questions and come to you as a patient.
And of course, I have my various clinics in the south of England, in East Kent and at Bromley particularly. So I mean, there are quite a lot of headache services around the country now, in hospitals and also in the community. It's my belief that we should have more in communities, and we should have a better expertise earlier in the sort of kind of hierarchy for the NHS. And I think there are more of those type of clinics as well. So it's a question of people trying to find someone they can work with. It doesn't have to be a doctor even. It could be that you've got a very interested nurse or somebody who can help. And as long as there's a network of people working together, hopefully we'll get better outcomes for patients.
Yeah, brilliant. Thank you, Andy. I really appreciate it, my friend.